All right, we're back, and we're back with Dr. Sabran. Sabran, what you got there? We got some more here. We're going to go over the final part of our show.
We're going to try.
Okay, we're going to bring up the slides, and he's working on that. And
I'm good in the cath lab, but PowerPoint is beyond me.
PowerPoint is good stuff.
Let me get through. One more slide I want to show you. I've alluded to it, but I want to show it to you, and then we're done with the academic part. This is what patients prefer. And if you look at these graphs, the patients who strongly prefer going from the wrist are on the left, and then it segues over to no preference, and then over to patients who enjoy going from the groin. And as you can see, patients that have had them both, and going back to the question of that we had earlier on the phone, I know a lot of people who have had multiple procedures done. I know a lot of people that have had multiple procedures done too. That's a very accurate statement. The patients that have had them done both ways vastly prefer going from the arm and would be more than happy to go from the arm again. And the numbers are about 90% prefer having it done radial. Mm-hmm. So I think from your point of view as consumers, this is a wonderful technique. It's done everywhere in the world, preferentially, except our country. And the reason it isn't done in our country is interesting. We were all trained, starting back in the mid-late 70s, we were all trained from the groin, as was everyone else in the world. And we really had no reason to change over here. The economic practice of medicine is not as pertinent in this country as it is in other countries. Our training programs have perpetuated going from the groin, and the fact that patients would stay in the hospital overnight, et cetera, was not that big an issue. And also, it's more difficult for us. It's something that we have to learn. It's a new technique, learning to use the catheters, even in people who have been doing these things for 20, 30 years. I've done probably 15,000 of these. It still was a learning process that took several months to do. So the incentives really weren't there until one realizes how much better it is for the patient and how much you all out there in the audience enjoy this compared to the other procedure. And then it becomes very gratifying.
How interesting. So how many stents can you actually put in a person's arm before it gets to be stented out?
Well, stents don't go into the arm. They don't go. They go into the arteries of the heart.
Right.
We can theoretically stent every artery in the heart from its beginning to its end. Theoretically, the longest stent that we have is 1.5 inches long. The arteries can run 4 or 5 inches long anyhow. Now that's very theoretical. We don't usually use stents that long, but I've got a number of patients that I'll put 3 or 4 stents into in one sitting. Usually that's all they need. And if they need much more than that, we're often looking at either bypass surgery or bringing them back for another procedure. There's the consideration of the amount of contrast media we're giving, time, fatigue for us, fatigue for the patient. But we usually don't put in more than 3 or 4 stents at one time. The arteries have to look right. They have to have the right blockages, but we can bring patients back. So I've had patients that have had 9 or 10 procedures. And the way that I look at it is this has saved them 2 or 3 bypass procedures. So it's not a bad trade-off.
So how does a person know? I mean, obviously they need to come see you, but I mean, what are some symptoms that they might have that might mean that they might have an artery that's shutting down or closing up? What are some things they should look for?
Well, interestingly enough, the most common symptom is not chest discomfort. The most common symptom is fatigue. The British did a study back in the 70s where they looked at the so-called warning signs of a heart attack. Because back then, there were no stents, there were no balloons, there was medical therapy and surgical therapy, and bypass surgery was a pretty risky procedure back then. So the British were very interesting in warning signs, because at that point, the British weren't hospitalizing their heart attacks. Part of the British health system, but there wasn't much you could do for a heart attack in the hospital at that point. There were no clot busters, there were no drugs, it was just bed rest. And what they found was about 95% of people, before having a heart attack specifically, noticed fatigue days, weeks, maybe a couple months beforehand. Just beginning to feel their age, they'd come home from work, they wouldn't want to do very much. So that's a huge warning sign to me when a patient of mine tells me, you know, I just don't feel as good as I used to feel. The next thing is discomfort. And the mistake that we all make is we ask the patient whether they're having chest pain. Usually angina is not painful, it's a sensation. And it's a pressure sensation. It's a sensation that feels classically like this, like a fist pressing the chest or someone grabbing the chest and holding them. It's a steady discomfort. It lasts anywhere from 2 or 3 minutes up to about 5 or 6 minutes. Usually brought on by exertion, relieved by rest, occasionally after meals, occasionally awakens people at night. It doesn't hurt worse with breathing. It doesn't hurt worse with doing this sort of thing. It doesn't hurt worse to touch. It tends to be midline. Doesn't have to be, but it tends to be midline. It does not have to radiate to the left arm. It does not have to radiate to the right arm. It can radiate to the back of the neck. It can radiate to the shoulders. It can be only present in the neck or the shoulders, but the characteristic of it, it's steady, it's oppressive, it doesn't necessarily hurt, generally brought on by exertion, relieved by rest. And that's the characteristics that we look for. And if you feel that, it pays to see one of us. I'd love to have you see me, but it's much more important than you see someone, than see no one. And let us make the determination. If you have that discomfort and it doesn't go away, there are 3 letters on your telephone, and that's 911.
So if somebody wants to reach you, Dr. Savran, how do they do that?
The office number is 1-800-CARDIAC, which is a pretty interesting phone number.
Yeah.
We got it in our practice.
I know.
We can always do that. I'm in Pahrump every Monday and Wednesday that I'm not on vacation.
And where are you at in Pahrump?
We're at Dr. Reiner's office on Monday afternoons, and we're at 1440 Calvada, Suite 700, which is right catty corner from Advanced Medical Center on Calvada.
Do they have to have a specialist referral to see you?
Depends on the insurance, generally not.
Okay.
Senior Dimensions requires a referral. Senior Dimensions always allows the referral, so that's not a problem. Other insurance plans, we're just happy to see you. I see walk-ins if I have to, but that sort of disrupts the office.
Right.
But I do if there's an issue. And certainly walking in and making an appointment is perfectly fine. And if it's something that needs to be seen, we'll see it at the same time. I'm in a group of 21 cardiologists in Las Vegas. I'm the only one that goes out of town. I've been going to rural towns in Nevada since the mid-'70s. I really enjoy it. I've got a pilot's license. When I was in Reno, I flew to every town you could fly to. Dirt runways, gravel runways, big runways, no control towers except Reno.
All right. So you're going to be here.
I enjoy this.
You're going to be here next week as well?
I'm going to be here next week.
And what are we going to talk about next week?
Next week, as far as I'm concerned, is a potpourri. I can give you my attitudes toward what you can do to keep from seeing us, which is probably more important to you.
All right.
And happy to field questions.
All right. Well, that's about all for tonight. We do thank you for watching. I do thank you for coming up too. I know, I mean, you're very nice to take time to come on the TV station here and do that. But he is one of the only independent doctors left in Pahrump, and he's here to help you. So give him a call over there, and we look forward to seeing you again next week. Have a good night.